Okay, coming into the fifth session of the videos, this session will be about chamber enlargements. So even though ECG is more about the electrical activity of the heart, it can give us some idea about the chamber enlargement. Nowadays, we all depend upon the echocardiogram to diagnose chamber enlargement, but still ECG can give us few clue. It has a less sensitivity but very good specificity in picking up chamber enlargement. The basic concept is that the chamber which is enlarged will have the electrical vector directed towards it. The direction of vector will be towards the chamber. That will give us an idea about chamber enlargement. So the four chamber enlargement we will be discussing in this topic are the right atrial enlargement, left atrial enlargement, the right ventricular hypertrophy, and the left ventricular hypertrophy. And sometimes we can use a biatrial enlargement or a common ventricular hypertrophy. All these things we will be discussing in this chapter. So before jumping into the details, we have to know about few things about the P wave. We all know P wave, literally P wave does not represent SA nodal activation. P wave actually represents the wave of depolarization that travels from SA node to reach the AV node. It includes both right atrium and the left atrium. Okay, so which leads you should look? This is very important. Which leads to look is a lead 2 and V1. These are the two leads we have to look for P wave. For looking P waves, the normal amplitude will be up to 2.5 mm in height and up to 2.5 small box width. This can be the normal P wave. Normal P wave height and normal P wave width will be up to 2.5 mm in height and 2.5 mm wide. Now, why you should look at how does it look in lead 2? How does it look in lead 2? Lead 2 will have a positive P wave, whereas V1 will have a biphasic P wave. And why does this difference is? This is because both the in lead 2, both the P waves, both the wave of amplitude goes directed inferiorly. So both the first part of P waves, we'll jump into it. The first part of the P wave is because of right atrial depolarization, whereas the second part of P wave is because of left atrial depolarization. This is very important. The normal P wave you look indicates the depolarization among both the atriums, and the first part indicates right atrium, the second part indicates the left atrium. So coming into this ECG, if you see the first part of lead 2, the first part of the P wave is by the right atrial depolarization, and second part is by the left atrial depolarization. The right atrial, both the right atrium and left atrial depolarization are directed towards the lead 2, so they will produce a positive P wave. If you look into V1, the right atrial depolarization will go towards the V1, whereas the left atrial depolarization will go away from the V1. So the left atrial depolarization produces a negative wave, whereas right atrial depolarization will produce a positive wave. This you should know. So V1 it will be biphasic, and lead 2 it will be a single P waves. Okay, now we go into the topic major, the right atrial first we will discuss about the left atrial depolarization. What are the cause of left atrial enlargement? How does it appear? The left atrial enlargement, how does it appear on ECG? First thing, left atrium is more about the width, and the right atrium is more about the right atrial enlargement will be more about the height. So this is the basic example. We'll discuss the points in detail. So left atrial enlargement will produce a few characteristic changes. The first one will be a wide P wave. So the first one will be a wide P wave. So we said that P wave will normally be up to 2.5 small box. Here the P wave will be up to 3 small boxes, and 3 or more than 3 small boxes, or that is equal to equal to 120 milliseconds. You know, one small box is equal to 40 milliseconds. The second one will be the P wave will be notched, and the duration between the two peaks of the notch will be more than 40 milliseconds. The duration will be between the two peaks of the notch will be more than 40 milliseconds or one small box. The third point will be that, and the terminal, if you look at lead V1, we said the terminal negative P wave. Now, this terminal negative P wave will be more than 1 mm in depth or more than 40 milliseconds in duration. So, the terminal negative P wave will be going deeper more than one small box, and the width will also be around one small box. So that is important. So what do you mean that what does the left atrial enlargement looks like? It just looks like this. This is the, you consider this is the normal P wave, and what happens here, you see there is two peaks. The P wave has become wider, and there are two peaks, and the distance between these two peaks will be at least 40 milliseconds or one small box. And then if you look at lead this thing, the lead V1, we have a negative P wave which is very long and which is also very tall. This should be more than 40 milliseconds or more than 1 mm in duration. This indicates the left atrial enlargement. Okay, I will show you ECGs depicting the same. Now this is called as the P mitrale. Left atrial enlargement is called as P mitrale, and we see the difference between the two peaks is more than 40 milliseconds, and we have got the total width of this 1, 2, and 3 small boxes. There are 3 small boxes. The total duration of P wave has increase in the duration of P waves, and here you see that the distance between the two peaks is more than 40 milliseconds. This is the first point. This is the second point. And the other one will be the terminal negative Q waves. So the terminal negative Q waves, the duration will be more than one small box. So this is the third point. This is the third point. And the fourth point will be this depth. The depth is more than 1 mm. So 4 points depicting the left atrial enlargement. The width will be increased. The distance between the two peaks will be increased. This is lead 2. In V1, both these are V1, we have the increase in depth of the terminal P wave, and also we have a wide terminal P wave more than one small box. All these 4 findings constitute the picture of left atrial enlargement. So along with this, another clue will be the left axis deviation. That there is another clue which will suggest left atrial enlargement. So what are the causes for left atrial enlargement? So this is very simple. Any mitral valvular disease, MS or MR, mitral valve disease, then any patient with HOCM or hypertension or aortic stenosis, anything causing the LVOT obstruction or a mitral valve obstruction will increase the left atrial enlargement, will cause left atrial enlargement. Now the difference comes in the sensitivity and specificity. As I said earlier, all these are very specific. All these signs are very specific, whereas the sensitivity is very low. If you consider this left atrial enlargement, if the negative phase is more than 0.4 seconds, the negative phase, if it is more than 0.4 seconds, that has got 80% sensitivity and 80% specificity. This is in the V1. If the duration is more, negative phase duration is more than. Okay, coming to the second topic, this will be about right atrial enlargement. So what is right atrial enlargement? Right atrial enlargement is given in ECG by means of 3 findings. First one will be there is increase in the P wave amplitude. Increase in the P wave amplitude more than 2.5 meter small box. 2.5 small box, it will be enlarged in lead 2. If you consider V1, increase in P wave amplitude more than 1.5 small box in V1, and then third one will be right axis deviation, P wave axis. This is right axis deviation of P waves of more than 75 degree. These 3 findings gives evidence of right atrial enlargement. If you look at this ECG, this is a clearly, you look at lead 2, you just see the number of P waves. P wave starts from here and goes up to here. You can count 1, 2, 3, 3.5. There are 3.5 small box. And clearly you can see that P waves are very tall. This is a classical example of what is called as P Pulmonale. This is the first finding. The second finding I will see is that lead V1 if it is more than 1.5 small box. You can consider, you can see here 1, 2, 3, 3.5. This is also more than 1.5 small box. So these three findings, if the P wave amplitude is more than 2.5 small box in lead 2, or P wave amplitude is more than 1.5 small box in lead V1, and if it is right axis deviation P wave axis, then you have to think in terms of P pulmonale right atrial enlargement. When there is right atrial enlargement, what are the causes? That is something we all know. Anything cause any tricuspid stenosis or an Epstein's anomaly or a pulmonary stenosis or a pulmonary hypertension or RVH because of any cause can also cause right atrial enlargement. All these things are examples of right atrial enlargement. What is the bi-atrial enlargement? Bi-atrial enlargement is given by it's a combination of both these things, where both the height as well as the width can increase. If you see, this is a normal ECG, this becomes wider than the normal ECG, and this becomes taller than the normal ECG. So this is example of both right atrial and left atrial enlargement. This is seen in lead 2, and V1 will have both again same normal change will be very exaggerated. Both the height as well as the width of the P wave will be increased in both lead 2 and V1. This is examples of bi-atrial enlargement. Bi-atrial enlargement can it be seen? Any patient with restrictive cardiomyopathy with MR or a constrictive pericarditis, all these conditions can have bi-atrial enlargement. Both the atriums will be massively enlarged and the ventricles will be of normal size. This is the classical examples. So we are done with the atrial enlargements. Now going into the concept of ventricular enlargement. So before jumping into the topic, we should know how the QRS waves, how the ventricles are activated. The first step is the septal activation. Septal activation, remember, occurs from left to right. Okay, so this produces a small R waves. Small R wave in V1 as well as a small Q wave in V6. This is an indicator of septal depolarization. Then the second is the ventricular depolarization. Although both of them will get depolarized at the same time, the ventricular depolarization, the issue is that LV is the predominant ventricle and it has much larger muscle mass. So the ventricle, if you see lead V1, will have a deep S wave. And since it is directed towards the ventricles, V5, V6 will have a taller R waves. So tall R waves in V5, V6. This is a normal ventricular depolarization. So what we will have, you have in V1 we have a small R and a deep S waves, and V6 will have a small Q and a tall R waves. So this is the normal ventricular activations. Series of ventricular activations. Now going into the concept between pressure and volume overload. So pressure overload. What is pressure overload? Any condition which can cause LVOT obstruction or an RVOT obstruction or a tricuspid or mitral obstruction that increases the pressure that result in concentric hypertrophy. That is example of pressure overload. Conditions includes condition for LV pressure overload includes aortic stenosis, HOCM, and any hypertensive heart disease. All these increase LV pressure overload. For RV pressure overload, you have to think in the same thing: pulmonary stenosis, pulmonary hypertension. All these things will increase the RV pressure overload. Volume overload. Volume overload is similarly any regurgitant lesion or any shunt lesions, congenital heart disease, they produce volume overload. LV volume overload is in this form of MR, AR, all these things can cause LV volume overload. And again, other congenital heart diseases, ASDs, those things can also cause volume overload, RV volume overload. ASD will cause RV volume overload. Okay, this is the difference between the pressure and volume overload. So what is the, before jumping into the ECG findings, we have to know what are the what is the secondary changes and what is the CAD changes. See, you consider this is an RBB, we know that we will have a ST changes like this, whereas in a CAD we will have this thing like this. So this is the primary STT changes and this is the secondary STT changes. So we all know, previously we know that depolarization moves from endocardium to epicardium. We know that, and we also know that repolarization occurs from epicardium to endocardium. Even though these are relatively opposite events, because their directions are opposite, we have a normal, say, positive QRS as well as positive T waves. This is a concept we already know. So what happens when there is an increase in LV mass or some conduction block? What happens when the LV mass increases? In our left ventricular hypertrophy, right stenosis, LV mass increases, or when there is a conduction block, what happens is that it takes long time for the depolarization to complete from the endo to epi. The time is long. So the repolarization cannot wait for depolarization to be completed. Hence, repolarization also starts from endo to epicardium. Because the time taken for depolarization is very long, the repolarization wave cannot wait. It starts from endocardium to epicardium. This results in that T wave which is in opposite direction to the QRS complex. So this is what is called as the secondary STT changes. So the difference between the secondary STT changes and the primary STT changes is that if you just look at this image, what you can find, there is a normal ST segment. ST segment is normal. Here the ST segment itself is downsloping. This is a very important point. The second point you can see is that the T wave is symmetrical. The descending limb and the ascending limb, both these limbs are equal. It comes, it descends and goes. Both the limbs are equal. Whereas you look here, the descending limb is sharp but the ascending limb is tall. So there is asymmetry. Asymmetric T inversions. This is symmetric T inversions. And this will be usually very deeper and arrowhead pointed, and this won't be that much deeper. And the QRS is somewhat not so normal, whereas here the QRS complex can be normal. This is a distorted QRS complex are there. These are the basic difference between the primary and secondary STT changes. So you have to know this. Okay. Now coming to the LVH proper, as I said, LVH can be of two types: volume overload and pressure overload. So in the pressure overload, you have the secondary STT changes. I've told all these things only to mention this point. Pressure overload will have secondary STT changes, whereas volume overload, there is no STT changes. So this is important. So pressure overload will produce secondary STT changes like this. If it is not there, then you can think of volume overload. Okay, jumping into the ECG criteria. First, there are LVH. There are numerous criteria. Again, just like axis calculation, LVH can also have numerous criteria. So you should remember one or two criteria to identify LVH. So the most commonly used one is called as the Sokolov line criteria, where the S wave in lead V1, S wave in V1 plus R wave in V6. If it is more than 35 small box, then you can consider it as voltage criteria positive. Then AVL if it is more than 11 mm, then also it is considered to be voltage criteria positive. Then the other criteria is called as the Cornell criteria. Cornell criteria uses lead AVL and the R wave in AVL plus the S wave in V3. If this is more than 20 mm in female or 28 mm in male, that indicates there is LVH. So I'll explain with an ECG. You look at this ECG. You see this S wave is very deep and this R wave is very tall. This is a normal phenomenon. But this is an exaggeration of the normal phenomenon. Normally, also you will have a similar expression, but you see the height of the S waves. You just calculate the number of boxes. See, it is 1, 2, 3, 4, 5. And around like, and you calculate the number of small boxes. Here it is 3, and 5 here, 5 here, 5 here, and there it is 4. So totally 15 plus 4, 19 plus 22. We have 22 here. And if you look at this box, you can again measure. This is 5, 5, 5 and 3. So 15 plus 3, 18. So here 18 we have and here 22 we have. We would add 22 plus 18, we get around 40. So that indicates the first criteria. The Sokolov line criteria is fulfilled. More than 35, here it is around 40. So this indicates there is evidence of LVH. The other criteria which you can say is that AVL. The AVL has more. It should be, if it is tall, it is up to the, if it is like this, more than 11 small boxes, then also you can consider it as LVH. But in this ECG, there is no evidence of the AVL criteria to be positive. So any one is enough. So this is the first point. The second point you have to say is that you have to look for the secondary STT changes, one which we discussed here. The downsloping STT changes, secondary STT changes. When there is evidence of secondary STT changes, think of pressure overload. This is an example of pressure overload, LVH. So we have found out there is LVH by calculating the axis number of small box, and we have also found out the pressure overload by looking into the secondary STT changes. So this is an example of LVH pressure overload. You look into this ECG. This ECG, there is no evidence of volume overload, pressure overload. You just see the pressure, there is no secondary STT changes. These are all examples of volume overload than pressure overload. When these findings is there, you have to think it as pressure overload. When there is not there, when the ECG looks like this is example of volume overload conditions. The LVH criteria is not meeting, but it is an example of absence of secondary STT changes. Okay, now we then go to the RVH. So what is the criteria for RVH? So first we have to know that the first one is that if the R wave in V1, if it is more than 7 mm, or if there is RS ratio in V1 is more than 1 with R wave is more than 5 mm. This is also. Then third thing is that right axis deviation, and then R wave. Right axis is mainly a supportive criteria. R wave in V1 plus S wave in V6 if it is more than 10.5 mm. Or there is monophasic RSR dash pattern or R dash pattern if it is more than 10 mm in V1, that is also indicative of RVH. So there is 5 points. Basically what we say that normally the R wave in V1 should be a small r. If the same R1 in V1 is, if it is very tall, then you have to think in terms of right ventricular hypertrophy. So see here, this example here, the R wave in V1 is around 5, 10, 15, 14 small boxes. So there is definitely an evidence of right ventricular hypertrophy. And you see the RS ratio. The R is very tall, whereas the S wave is very small. So RS ratio is definitely more than 1. And there is no RSR dash in this ECG. I mean, even if you look close, yeah, this is the R, this is the S, and this is the R dash. R dash is very prominent. R is R prime. This R prime, we see it is more than 10 mm. That is also indicative of RV enlargement. And one more thing you can see is that the secondary STT changes. The secondary STT changes indicates it is an example of RV pressure overload. When there is an RV pressure overload. When there is no secondary STT changes, you have to consider it as RV volume overload. One clinical point is that ASD. ASD is a condition where you have RV volume overload, but this volume overload selectively affects the RV OT. So this will tend to pull the terminal part towards the right, and we have a pseudo RBB like pattern. Pseudo RBB like pattern will be seen in ECG. This is one with the secondary changes. Conduction abnormalities can also have secondary changes. So this is one condition where volume overload condition with secondary changes. This is one such examples. Then we go into other condition. This is biventricular hypertrophy. Biventricular hypertrophy is a rare condition where there is evidence of LVH plus RVH. That clinically we can have if there is an LVH with a right axis deviation, or an RVH with a left axis deviation, or something called as Katz-Bachtel phenomenon that's seen in VSD, equiphasic QRS complex over the precordial leads. They are seen when there is VSD where there is common ventricular hypertrophy. So these are examples of biventricular hypertrophy where there is more evidence of both RVH and LVH. So this sums up the findings of chamber enlargement. So 3 points. Radiated enlargement is based on height, more than 2.5 mm in lead 2, more than 1.5 mm in V1, and right axis deviation. Left atrial enlargement is because of in the width more than 3 mm or the between the two elevations if it is more than 40 milliseconds, or the negative V1 showing the negative terminal is more than 40 milliseconds width or 1 mm in depth. All these indicates left atrial enlargement. The LVH, again these two criteria, S wave in V1 and R wave in V6 if it is more than 35 mm, or AVL more than 11 mm, or if there is tall V R wave in V1 more than 7 mm. All these indicates different hypertrophies. So thank you.